Okay, we're live.
Good morning. I will call the meeting to order. Good morning, all. Looking forward to our discussion and continue to remain grateful to our board members, Audrey and the whole Health Connector team for their commitment to this work and the people and families that we serve. So I think the first item on the agenda is to take roll call of all of our members present. Kathy?
Okay, good morning, everyone. Rebecca?
Present.
Michael?
Present.
Elaine?
Present.
Bella?
Present.
Eric?
Present.
Martha?
Present.
Robin?
Present.
Dimitri?
Good morning, Kathy. I'm here.
Good morning. Nancy?
Good morning, Kathy. I'm here.
Good morning. And Matt?
Yep, I'm here. Thank you.
And do we have anybody from EHS? Nope. Okay. That's it. Thank you.
Okay, thank you. Thank you. It looks like we will kick off with the approval of the minutes from our January 11th meeting. And so I'll entertain a motion to approve the minutes.
So moved.
I'll second.
Okay, Kathy?
Okay. Again, Rebecca?
Yes.
Michael?
I think I need to abstain because I was absent last meeting.
Okay. Elaine?
Yes.
Bella?
Yes.
Eric?
Yes.
Martha?
Yes.
Robin?
Yes.
Dimitri?
Yes.
Nancy?
Yes.
Matt?
Yes.
Thank you.
Okay, thank you. Thank you all. The next item on the agenda is the executive director's report. And so Audrey, you have the floor.
Great. Thank you so much, Madam Vice Chair. Good morning, everyone, and welcome to today's meeting. We have a lot of forward-looking material today as we continue to prepare for plan year 2025, reminding ourselves that all of the careful preparation we put into 2024 paid off with our highest impact open enrollment in a decade. The open enrollment period that just concluded on January 23rd was a momentous one for us as we continued to support enrollment of residents losing MassHealth coverage due to ongoing redeterminations, launching our 2-year pilot expansion of Connector Care, and investing in some of the most fulsome community-based outreach and multi-channel media work we've done in years. In the end, here's where we landed this open enrollment. More than 72,000 new people enrolled in Health Connector coverage during open enrollment, and we now have more than 287,000 people in non-group health coverage. Once you add in standalone dental and small group health coverage, nearly 330,000 people here in Massachusetts have health or dental coverage through the Health Connector. That's our largest all-in enrollment number ever. We were able to implement our pilot expansion of Connector Care seamlessly for the 36,000 current members moving into the program and welcomed an additional 10,000 new to the Connector enrollees into the expanded Connector Care space. We currently have 234,000 people now in Connector Care plans, the largest number ever in our flagship affordability program's history. And the great news is when we zoom out to the national picture, we were not alone. According to CMS, 21.3 million Americans are now in ACA marketplace coverage as state-based marketplaces like ours and healthcare.gov delivered access to affordable care to more people than ever before. Our enrollment increases have been driven by our continued diligence around redeterminations. As of this week, 95,000 people who were found ineligible for MassHealth and newly eligible for the Connector have enrolled in a marketplace plan since last April. According to CMS, through October, our redetermination-driven signups accounted for 1 in every 5 Medicaid redetermination plan selections in the nation's state-based marketplaces. 1 out of 5 of them is us. Through the redetermination process and open enrollment, we have leaned heavily on outreach and our call center and other member supports to ensure everyone who has coverage gets it. For the most part, those processes have held up. We did have some call center slowdowns around the 23rd deadline in January, not due to operational stumbles, but because call volume was exponentially higher than forecasted. But we quickly implemented a callback operation to ensure everyone who called us was contacted. We still have work to do on redeterminations. Thousands more residents will become eligible for Connector coverage through the spring, and will continue to work full tilt at enrolling as many people losing MassHealth as possible. But as you'll hear today, we are also turning our attention to 2025 and beyond. This week, we published our notice of grant opportunity for our Navigator program. We are moving to a 3-year cycle, creating additional stability for both our team and our partners. We have grown and nurtured our Navigator program over the last decade and now have 22 organizations that provide vital assistance and outreach in 29 languages all across the state. Our navigators conduct some of the connector's most vital work in communities across the Commonwealth. We look forward to providing details on our grant awards to the board later this year. Today, we will seek your approval on the first two items for 2025, setting affordability standards and minimum creditable coverage requirements. These annual updates relate to the state's individual mandate, which impacts roughly 5 million Massachusetts residents. Today, we will also preview our seal of approval plans for 2025 in advance of issuing an RFR to the market. Our goal for next year's seal of approval is stability. With the 2-year Connector Care expansion pilot and welcoming all carriers into Connector Care this year, the 2024 plan year was intensive from an operational and policy perspective for us and carriers to prepare for and implement. While holding the line on stability for this year, as the team will detail, we are aiming to lay foundations to support enhanced focus on maternal and cardiometabolic health in alignment with the broader health equity agenda of the Healey-Driscoll administration under EHS's leadership. As we look down the road to 2026, the future of the currently enhanced federal ACA premium subsidies and other larger issues may be on the table pending congressional direction, giving us further reason to hold steady in 2025. All of this forward-thinking work aligns with the goalposts laid out in our 5-year strategic plan, which we presented to you last month, and we thank you for your support on. We look forward to being back with you soon with even more detailed work plans and approaches for measuring our progress as we begin implementing the plan this first year. As a marketplace, the strong position we are in is thanks to the hard work of this entire team over the last year and this board's steadfast support throughout. Thank you again for your guidance and enthusiasm for our work, including these early steps towards 2025 that the team will detail today. With that, I will hand it back to our vice chair.
Thank you so much, Audrey, for the report. And as Audrey mentioned, we will move on to our next agenda item, which is an update on the MassHealth redeterminations and open enrollment of 2024. And our presenters will be Marissa Waltman, Patricia Grant, Jason Leifert, and MassHealth Chief Operating Officer Elizabeth Lamontagne. So Marissa, will you kick us off?
Great, thank you. Good morning, everyone. So as Audrey noted, we saw a strong open enrollment with more than 72,000 new members, bringing February's enrollment 37% higher than last February's. While enrollment from individuals who lost MassHealth during 2023 was certainly a component of this increased enrollment activity, we saw increases among those who did not have MassHealth last year, relative to what we've seen in the past few years as well, suggesting that this strong growth is a product of the Health Connector's robust outreach, as well as greater opportunities to receive help paying for coverage from a broader array of plans than ever before. Today, we'll shake things up a bit, covering outreach and call center performance during open enrollment prior to discussing the resulting enrollment changes, but we'll start, as always, with an update from MassHealth.
Thanks so much, Marissa, and thank you all for letting me join today. MassHealth, the redeterminations process began in April, and through the end of December, we've initiated renewals for about 1.35 million members. As a result, we've seen our caseload decrease by about 282,000 members, from 2.4 million or so to about 2.12 million. In December, we saw 133,000 members depart coverage, an expected and annual trend that we see, where we have an increased volume of departures in December, given how we align our operational processes with some of the Health Connector open enrollment process. To put these numbers a little bit more in context, prior to the COVID-19 public health emergency, we saw about 52,000 members depart MassHealth coverage every month. Since April 2023 and the start of the redeterminations process, we've seen about 65,000 members depart monthly. This increase is expected, one, because our caseload grew significantly from prior to the COVID public health emergency to when this process started in April, and two, because we know a number of members on our caseload who normally would have lost coverage because they were no longer eligible, had their coverage protected during the public health emergency and are now going through that renewal process. Throughout this process, we've remained focused on our 3 core goals. The first being preventing administrative loss of coverage as much as possible, especially for those who are most vulnerable. Making sure members understand what action they need to take to make sure they receive the appropriate benefit, whether it's responding to that blue envelope, updating their contact information, or reaching out to resources in the community for help. And of course, making sure we're maintaining compliance with federal and state requirements. If you want to flip to the next slide, I can share a little bit about the work we've done in December and to date, really focused on preserving coverage for eligible individuals. For the redeterminations process, we stood up a number of new and really expanded some of the supports we had in the community for members. And we've seen those really have an impact. Health plans have made over 1.3 million outreach attempts to support members who are up for renewal, calling them to let them know their blue envelopes on their way, offering if they need help. EHS also executed over 2 million of grants to expand community assister capacity at 23 CBOs, serving immigrants, refugees, older adults, and other vulnerable populations in partnership with Healthcare for All. And we also expanded assister capacity at Aging Service Access Points, or ASAPs. Through these grants, there are now 108 new trained assisters in communities across the state available to help members with their renewals, answer questions about MassHealth, and help them understand what to do if they get a blue envelope in the mail. These assisters have served over 3,000 households with over 3,400 hours of member support, whether it's direct support or office hours being held at a local community area. They've held nearly 200 population-specific events, trying to get the word out to folks that this is important and the key steps they need to take. And they've done even more in their communities as well. On the customer service side for MassHealth, we saw a significant increase in volume in December, but we continued to manage that volume. Our average speed to answer was about 2 minutes with an abandon rate of about 2.6%. And in December, our enrollment centers were busy as well, supporting over 11,000 appointments or walk-ins with members. And this includes in-person walk-ins, a virtual appointment, or a telephone appointment as well, which are all great avenues for members to get direct support on their renewal or their application. Happy to answer any questions or hand it back to Marissa.
All right, great. Thanks, Elizabeth. Good morning, everyone. Starting with open enrollment, this open enrollment was a little bit different than in the past, where we were messaging not only to uninsured, but also to folks who are moving from MassHealth through the redetermination process. We focused a lot on robos, email, and texting. In past years, we've learned that robocalls are really effective in terms of spurring action. We started broader texting campaigns this year during redeterminations. And we found that those are really effective, getting messages right on the device that never leaves anyone's side. We also leveraged email as a significant tool around the deadlines. We ended up sending out more than 900,000 email to unenrolled and eligible people in the days before the deadlines. And we saw really extraordinarily high open rates early in the week, 57 to 60%. As expected, those diminish as the week goes on and people get a daily email down into kind of high 40s, but that's still really significantly stronger industry-wide of low to mid 30s for open rates. Direct communications were supported by our in-community activities, which included some of our now traditional and effective standards like holiday events and mall visits, along with stops that were new and targeted to the gig economy and potential connected care expansion members, stuff like our in-arena during Bruins games and information sessions at co-working spaces. Also, just note real quick, one last thing, one of our kind of old school activities, lit drops, continue to be effective in delivering static messaging throughout open enrollment. We posted 1,500 window signs and dropped 4,200 flyers in 13 communities around the state. Next slide, Marissa, please. Thanks. On paid and earned media.
Jason, could I ask a question? I'm sorry, I was muted.
Sorry.
Do we have anything that's focused specifically on young men? And I'm asking partly because it looks like both of the people you're showing in these are women, and we know that the people who are uninsured are disproportionately young men. They always have been, they continue to be. So anything specific, maybe the Bruins, but I know a lot
Yep,
of women like the
Bruins.
Bruins too. So like what
Bruins
what are we
only
doing
put that
there?
category. We did have some art that focused on young men. This was sort of a rotating. The photos changed depending on the audience and the location. We definitely had some young men in the mix there. And we also did texting to under 35s coming from MassHealth. And obviously men were part of that as well. So they definitely heard from us as usual. On paid and earned, obviously less targeted compared to direct communications in community activities, but good broad visibility. Still focusing on communities with higher uninsured rates or platforms that reach potential connected care expansion populations this go around. As in past years, we did dozens of interviews with print, TV, radio, and digital outlets, often focusing on impending deadlines or the start of open enrollment. Many of those interviews are done by navigators, which is really helpful in terms of delivering information in languages that are important in their organization's communities. This year, we did find really solid success with op-ed placements. There were 600-word pieces signed by Audrey, included local details, including connected care expansion numbers and quotes from local Health Connector members to highlight open enrollment offerings. Getting nearly a dozen of those in December and January was definitely an earned media highlight for us this year. On the paid media side, across all platforms, we generated more than 14 million impressions that range from targeted Spanish language media to Boston 25 and T advertising. I know there was a question at the last meeting about T advertising. We didn't have any hard copy spots in T stations. It was all digital. So there was one occasion where a station closed and the digital inventory for that station was moved elsewhere. We contracted for a minimum of about 1.2 million impressions during the campaign, and the T delivered 4.3 million impressions. And that's kind of consistent with past campaign results there. Overall, that out of home has delivered for us in the past and continued during open enrollment. Also effective, as kind of usual, were social media and digital activities. YouTube pre-roll ads and LinkedIn ads both garnered 1.7 million impressions each. And in addition, our internal team rolled up an additional 600,000 impressions through Facebook, Spotify, and Google ads. And then really kind of like on the more local level, we ran 2 advertorial pieces in the Dorchester Reporter, and those averaged more than 18,000 online visits for each piece. Notable in that Dorchester is one of our largest communities in terms of connected care membership historically. So it's good to see that strong readership in an influential neighborhood publication. Nancy, do you have another question?
I do. So it sounds like we're doing a lot, and this all is very impressive in terms of the scope and the amount of it. How do we figure out which of these is actually most effective at not only being seen, but leads people to take some action? Do we know, how much do we know about that, like from many, many years of doing this?
Yeah, so, some stuff we can obviously see kind of directly, particularly digital, in terms of click-through rates and that kind of thing. We can see video, how many times somebody watches an entire video compared to just part of it. And we have that info, but traditionally, some of like the T or Boston 25, like that broad-based stuff, we don't know how many people are motivated, by one ad to go online or give us a call. But having that sort of broad-based foundation, getting the word out, it's kind of just part of the overall atmosphere as we put this together. If that makes sense.
But I think, Nancy, that's something we can take back and it deserves a closer look in terms of trying to draw linkages between each of these and what might have prompted someone. Like Jason said, it is atmospheric. So somebody might hear us on the radio, see us on TV, click a thing, and then that all together leads then where we want to go. But we do have surveys that we can use to ask people, how did you hear about the connector? What prompted you to sign up and that type of thing. So I think this year we can spend some time thinking about how we get a little more granular in our analytics about what's the most effective place to put resources on outreach.
Yeah, I think that would just be very useful for us to know. And I imagine with the great relationships we have with some of the other state-based exchanges, all of which have been doing a variety of things, probably some of which are the same and many of which are tailored to their particular state context, just would be, I think really helpful so many years in to this, just to know what have we learned about what the most impactful forms of outreach and enrollment are.
That's great. Thank you, Nancy, for that question. I appreciate it. Eric, I believe you have your hand up.
Thank you. First, I'll just say that I've seen plenty of the ads on the Boston Celtics games, and for trying to get to young men and women. I know the NBA is really popular, so I'd be curious to see if that's been effective. So that's a great spot. I also want to just formally congratulate MassHealth and the Connector staff for doing a phenomenal job through this process. As someone who's been in the health insurance business for 27 years now, something we always strive for is calm and quiet. We want things to work. We don't want there to be big, loud noise. And I was waiting all year to see if there was going to be something that was blowing up and big noise, hitting papers and lots of problems. And we didn't really see that. And so I think that's a testament to all the work that's been done, both at MassHealth and the Connector staff. So really kudos to you all for all the work you've done to try to manage this really complicated process. And related to that, I know we'll want to see some of the numbers, and I'm just curious when we see there's been a decrease in MassHealth and then an increase to some degree with the Connector enrollment. We know there's a little bit of a delta between those two numbers. Do we expect a timeline to know whether we're hitting our 97% insured rate still, or whether that's up or down? Any sense for when those numbers will be put together?
Marissa, do you want to take that one?
Sure. So we'll start to see some information trickle in on a state level from sources like the Division of Insurance and CHIA over the course of the year. Typically, the census data, which we would use to compare against other states, is released in the September timeframe. So we would start to see data then on a national level. And we'll continue to evaluate whether CMS will be putting out any additional information about coverage transitions nationwide that may come out over the course of the year as well. So there typically would be a bit of a lag, and we're still in the middle of the process, so it may not reflect our kind of final landing place. But I think we'll start to see data coming out probably this spring all the way through the fall that we'll be monitoring.
Okay,
if I could just add to that I think that's correct about the 97%, the really big picture question. But much more immediately, we will have data in hand about people who lost MassHealth and didn't come to the Connector. We're working with DOI. They collect data from carriers that we'll be looking at shortly that will help us kind of triangulate what's going on in other market segments. So grateful to DOI leadership for committing to work with us on getting that data pulled together as soon as possible. And then secondarily,
Did we lose Audrey, or was it me?
No, we lost Audrey.
Yeah, I think we lost Audrey. I
want to be sure we have a router
So
update in the budget.
I have a quick question for Jason while Audrey, until we wait for Audrey to come back. Jason, are you still with us? Oops, did we lose the building?
Yeah, it looks like maybe everybody from the Connector.
Oh, wow.
Benefits of working from home, Rebecca, huh? We're not subject to these
Yeah, I'll have to let some folks know.
Tell Eric, you jinxed it, saying there were no problems and no.
That's right. Internal problems are fine.
Yeah.
Just don't want external problems.
Yeah,
It's
no,
that
I
first time
completely
vice
agree.
chair luck, I think.
I was just gonna
Yeah.
say, Elaine, this is the luck for you, right?
You can't do the Wi-Fi troubleshooting at the connector office building? What kind of vice chair are you, Feline?
I know, my goodness, I didn't check that off my list.
Didn't see that in the job duties. Huh? Usually Dimitri's our tech
That's
guru.
true.
Yeah.
Now, anyone try to reach out to Audrey or anyone else at the connector to see if the building is out?
Check now.
Yeah, we'll reach out. We're taking care of that now.
Okay, great. Thank you.
In the meantime, we've got 60-degree weather coming this weekend. I hope everyone's excited about that.
I saw that.
Great.
I'm
Matt,
excited.
there's always a price to pay for that. It never just come and stay.
I'll pay the
We'll be
price.
punished for it on the back end.
Dimitri, come on, typical New Englanders. We're gonna complain when it's
About
hot.
anything.
When it's cold.
I can't see your background, Dimitri, but it looks wonderful.
It does.
Well, Rebecca knows this about me. I work on old classic cars, and I have a 1970s Cadillac convertible, and it will be on the road in
Nice.
60-degree weather on Saturday.
It's the most beautiful thing I've ever seen.
Oh my goodness, I love it. I love it. Looking forward to getting out without a heavier coat.
Marissa's back, looks like.
Apologies all. We seem to have lost internet here in the office.
That's what we figured.
Marissa, will we be able to tape the meeting, continue to do that, or is that going to be problematic?
I believe that we can continue on here. Let me pull up our presentation and do my best, Kathy. So I know Jason still has a few slides that he would cover, but perhaps I think Trish, if you're still on, maybe we could pivot to the contact center piece.
I am, sure.
And I can cover some enrollment, and if anyone has further questions for Jason, once he's able to get back on, we can circle back.
Okay, great, because Dimitri had a question. I think I had a question.
Oh,
Back.
okay.
Well, welcome back.
I got bounced when Audrey froze, so I had no idea what I missed.
Just came up with a whole ad campaign, Jason. I think you're really going to like it.
I'll have to watch the video when we're done. Thank you. I also had some issues. I heard Eric say he saw stuff on the Celtics, and then he asked his question about getting data, but I don't know if there's anything in between that he
Yes,
asked.
I believe Dimitri had a question.
Okay.
As well.
I do. So Jason, again, thank you for all the wonderful work that you and your team have been doing. And as Eric alluded to, I have yet to go to a Celtics game and not be bombarded by a Health Connector ad, or even watch a game on TV and not be bombarded by Health Connector ad, or drive behind an MBTA bus and not see a Health Connector ad. So definitely the ads are everywhere, and I think we're getting a lot of eyeball. As we focus on reaching the populations that we have not been very successful in reaching in the past, are we looking to other media that we haven't looked at in the past? For example, are we doing anything with the Bay State banner, which specifically target the community of color? Dorchester Reporter does a great job in Dorchester, but it targets a completely different population than the Bay State banner. So I want to see some of the, what are we doing in terms of micro targeting so that we can really hit at that 2 to 3% that seems to be fairly persistent with regard to our goal of getting to 100%.
Yep. So we do advertising and other outreach to the Bay State banner, and we do reach out to ethnic media, Spanish language, Portuguese, those are the two biggest, not only in terms of the proportion of people who speak those languages, but also have sort of the biggest media presence in the state. But we also, leverage Haitian Creole, local media, Cambodian media in Lowell and Lynn, for example. So we do sort of, piece together that puzzle based on where people are. And then we do work with some social media influencers, who are community leaders. And we had a couple of really good hits during this open enrollment, where they got the word out to their followers.
And to Nancy's point from earlier, are we capturing the analytics on the back end of these opportunities so that we know which ones are effective and which ones are not, based on either feedback from our navigators or whether or not we're tracking any the links to see where people are coming from, especially with the social media influencers, so that we know that they're being effective.
Yeah, so kind of what we're presenting today is sort of that sort of first blast of data that we have with open enrollment. I just finished a couple weeks ago. So we'll get more. We'll get more of that granular detail.
Is there anything in that is particularly problematic?
No,
Yes.
there's not.
The other
Yeah.
It's like, now I would say, like, maybe the alternative is
Martha, you're not muted.
On mute.
Oh, good.
Okay, great. Flane, did you have a
Yeah, Justin, maybe it's not a question for you, but I was just thinking on more of a kind of expanded outreach and grassroots efforts. And I know you focus on a lot of the electronic outreach, communications, and social media, but to the extent that, there are safety nets that are available to the population that we serve, what does outreach look like to, for example, food pantries and just other places where, it would probably be likely that this information would be extremely helpful? What does that look like? What has it looked like in the past, and what does it look like now?
Yeah, we do some of that. I'm trying to think of some particular locations we've been. There's one on the North Shore, I think, that we've been to that we have information. There are a couple of navigator organizations that also run food pantries. I'm thinking specifically the one of the navigators in the Berkshires runs a food pantry in Great Barrington, I think. And the New Bedford Navigator just opened a food pantry within the last year or so, that Audrey and I actually visited, I think, in the spring or late winter. So, yeah, we do make those connections where we can, because it is a great place for people to, get information on that.
Yeah, I would imagine so. Yeah.
All right, let's see if I can talk about redets before I have another router meltdown. So on direct communications for redeterminations, we did continue that work during open enrollment. There was obviously some crossover when we got into deadlines where redets people were getting open enrollment material. But we did keep up with people newly coming in from MassHealth to make sure they were getting sort of that introductory information and getting pointed in the right direction along with the open enrollment material as well. And we'll keep going throughout the spring. We anticipate people will be coming through the final MassHealth redetermination process and eligible to us later in the first half of this year. And we will continue to conduct that same direct communication outreach that we have throughout the process. One area that we're going to try to add communications around is people who have longer gaps between MassHealth and Health Connector coverage. I think during open enrollment, we saw a few thousand people a month enrolling who kind of fit that category. They may have been playing sort of that end of the year game, but we don't want to leave them behind outside of open enrollment. So this month, we're going to send those longer term folks messaging that reminds them kind of a special enrollment opportunity that alleviates any misperceptions on availability after they receive so many open enrollment is ending messages from us, last month. And then next month, we're going to send messages that kind of create a new urgency around the individual mandate and tax penalties, noting that if you haven't had coverage in 2024 after April 1st, your 90-day grace period is over and you could be subject to penalties. This will be doubly timed with tax season. So hopefully this message resonates and gets some additional enrollments. We have found traditionally nothing spurs action like a deadline. So if we're creating kind of a new deadline for people to take action, all the better. And then for visibility in 2024 on redebts, we're going to continue our broad visibility efforts around redeterminations. This will include some ongoing paid media, considering some expanded partnerships with Fox 25. They've been a good partner for us on redeterminations, on both the advertising side and the coverage side, and maybe getting back into Red Sox radio as baseball season cranks back up. I think Dimitri and Eric both said they've seen a lot of the Celtics stuff. Obviously, everyone's watching the Celtics, it seems like this year. I've heard more. We've done the Celtics thing for the last 2 or 3 years, at least during open enrollment, but they are clearly getting a lot of more eyeballs this year than they have in the past, because I've heard it from a lot of people. So hopefully the Red Sox are pretty good this year, and we can get some traction there as well. We're also planning a discussion soon with Lyft, potentially identifying some opportunities to connect with their drivers. Those would be gig workers who would quite possibly be going through MassHealth redeterminations, and also likely fit in that connected care expansion levels. So hopefully we'll have more to share there soon. We'll continue in community activities. We're lining up more than a dozen visibility events between now and at least the end of April, including participating in some annual traditional events like the Winterfest in Lowell and the Lunar New Year Festival in Quincy, and Springfield Together's Spring Party, which is around Easter. And then also on the visibility front, we're planning on a tabling series at T and commuter stations for a bit later in the spring when it gets a little warmer. We did this in the past. We did this pre-COVID, and it's, a pretty good, simple visibility maker. So we'll be in communities like Lynn, Dorchester, Quincy, Worcester, and Brockton for that, when the weather's a little bit nicer. So again, apologies on the technology front. If anybody has any questions, if not, I think over to Trish.
Thank you, and good morning, everyone. Overall for January, contact center performance improved over December and was more aligned to the higher service levels that we had maintained in the last half of 2023. A contact center was open this Saturday before the end of open enrollment, and we successfully handled 745 calls on that day. We did struggle a bit on the last 2 days of open enrollment due to call volume that was much higher than expected, and which came into the call center in waves during those 2 days. On Monday, the 22nd, we received 2,600 more calls than forecasted, which was a 16% increase. And on Tuesday, the 23rd, we received 800 more calls than forecasted, which was a 22% increase. While those percentages don't seem high, the volume was not spread out consistently during the day. We actually had intervals where call volume reached levels that were 300% higher than what was expected. Immediately after open enrollment on Wednesday and Thursday, we made 2 attempts to call back anybody who called us and was not able to get through on Monday or Tuesday. We also met with Accenture to review performance throughout open enrollment and to discuss lessons learned and potential improvements, not only for next year's open enrollment,
but also for our day-to-day contact center activities. Since the end of open enrollment, daily service levels have not dropped below 97%. And in fact, most of our days are above 99%. We are also seeing days with many more intervals at 100% than we've seen previously. That means that every call that hits us during an interval that's 100% is answered within our standard of 60 seconds. As an aside, I just received another report from the call center, and so far all of our intervals today are at 100%, which is great news. We do have a new account lead for our contact center contract with Accenture, Angela Hawkins. Angela spent some time transitioning to our account in December and started full-time with us at the beginning of January. We're extremely pleased to have Angela on our account, and in the short time that she's been here has made some very positive changes. A formal welcome to Angela, and we look forward to continuing to work with her. Happy to take any questions. Otherwise, I can turn it back over to Marissa.
This looks great, Trish, and we're always going to have periods where volume is unexpected, and
correct.
Lots of people do things at the last moment. But these are wonderful results. So congratulations to you and your team and Angela and her leadership.
Thank you. And many thanks to everyone, both at CCA and Accenture, who worked very hard to make our service levels much better than they have been in the past during open enrollment.
Thank you, Trish, for the report. Marissa?
Yes. So this chart on the right here shows our new enrollments, which we define as people who signed up during open enrollment and who weren't enrolled with us in a plan on 11/1. And it shows that for the last 6 open enrollment periods. You can see that for 2024, which is the yellow line here, we had a return to and ultimately a surpassing of the coverage levels from before Medicaid coverage protections were implemented in 2020, including a very strong last few days of open enrollment. New members were more likely to be under age 35 than renewing members at 46%, which you can see in the chart here on the left. We saw membership among this cohort decline over the last several years, and now it's climbing back toward pre-pandemic levels. New members were also more likely to identify as African American at roughly 10% compared to 6% of renewing members, as well as Hispanic at 23% of new members compared to 18% of renewing members. We know uninsurance is more prevalent among both Black and Hispanic individuals, so this is welcome news. On the language front, new members mirrored renewing members closely, with over half of enrollees expressing a preference for English, followed by about 9% for Spanish. New members were also a bit more likely to live in a community targeted for additional outreach support, given higher levels of uninsurance. 43% of our new members came from a target outreach community compared to 38% of our renewing members. Connector Care is really driving these enrollment gains. At 234,000 enrollees for February, membership is at an all-time high. And 86% of our new enrollments during open enrollment were into Connector Care. On average, members pay about $99 per month, though this ranges really widely, given the wide variety of household incomes that are served by the program. The pilot expansion to 500% FPL is also a strong driver of this membership high. 46,000 enrollees, including 10,000 who are new for 2024, qualify for coverage between 300 and 500% of the federal poverty level. And we've also noted here membership by carrier and income level, with most members enrolled in a plan with Tufts Direct or WellSense, and almost half of members having an income between 150 and 250% of the federal poverty level.
Marissa, can I just ask on that last slide?
Yep.
The 46,000 pilot members, 10,000 new enrollees. So 36,000 were those folks that were getting APTC before and then moved over into the Connector Care plan. So the 300 to 400?
Most of them were between, a kind of a steady income year to year, but their income now qualified them for Connector Care. We did see some individuals who had been in Connector Care at a lower income. Maybe they've had a change in their income for this year, or some individuals who had previously been unsubsidized who now qualified. So we saw a little bit of movement across the plan years, but by and large, these were people who were already in that income range and were newly eligible for the program.
Great, thank you.
Marissa, thank you for showing us the connector care data by carrier. Can you just remind me what's the total against which, for example, we would apply the United 3/100ths of a percentage point?
Yes, this is 234,000 enrollees overall.
Okay, great, thanks.
Transitions from MassHealth were also a strong driver of our open enrollment activity, with just under half of new members having lost MassHealth in 2023 and largely late in 2023. Over 90% of them had no gap in coverage as they transitioned. We continue to enroll 20 to 25% of the individuals who are eligible for a Health Connector plan coming out of MassHealth, a trend that's been very consistent over time. Of note, the latest national data released by CMS that outlines marketplace transitions by state showed that through October, the Health Connector accounts for 1 in 5 plan selections among those losing Medicaid in state-based marketplace states. And really that means that we've had more plan selections in absolute terms than even a state like California. And while we see that coverage transitions in Massachusetts have been consistent and comparing favorably to other states, we still do worry about people who are not getting coverage, but they might still need it, and thinking about how we can support them. We continue to see strong enrollment among people who are working with an enrollment assister, particularly among individuals who prefer a language other than English. And we really encourage individuals to engage with a local navigator to receive that support. We're working with navigators to be able to outreach to individuals in their areas who are eligible but not enrolled, or who still need to submit a payment to make sure that they have the support that they need. Any questions on the enrollment trends?
I have one more question. The enrollment across the health plans, is that distribution changed drastically compared to last year, or is it very similar?
No, it's been relatively steady. I don't think I would say that there are drastic changes, but we could certainly get a comparison for you for more detail.
I'm just curious.
Right.
This is Rebecca. I had a comment. I just wanted to say that we at the division are very appreciative of the connectors' efforts in the area of making sure that people actually get to the connector when they're looking for plans. We've noticed that there's a significant drop-off in our complaints from recently enrolled individuals who accidentally enrolled in fake connector plans, and we have noticed ourselves that the real connector is appearing high up in the Google searches as they come up, and so your efforts there are definitely appreciated, and we hope to see them continue. So thank you so much, and for your hard work in that area, which is always problematic.
Thank you so much, Rebecca. Appreciate that.
So looking ahead, although open enrollment is over, the redeterminations process is not, and we'll continue to have special enrollment opportunities throughout 2024 for individuals losing MassHealth, including those who lost MassHealth during 2023 and have been eligible for a Health Connector plan but did not enroll during open enrollment. We'll plan to carry forward our learnings from open enrollment, including a continuation of targeted outreach to eligible individuals under age 35 and other successful strategies. And we'll continue to gather new information in the coming months with surveys of our members and applicants, and with data becoming available from other sources about broader market coverage changes. And as always, we will be back with updates on our progress. Any last questions before we close this out?
And if I could just add, because I know I got cut off, and sorry for the internet debacles. I don't know how much of my prior comments got lost there, but I did just really want to underscore how hard we're working to find data about people losing MassHealth who are not coming to the connector, including a forthcoming survey. So I might have got cut off there, but just want to let folks know we're working with DOI on administrative data and that survey, because we know that's really vital to understand how we're faring. And I think we'll be able to triangulate well before survey data about statewide coverage to try to understand where there may be exposure due to redetermination, so the Commonwealth can target where we need to be extra focused. So thank you for the focus on that, and we'll be in touch on more data. But Eric, I see your hand as well.
Thank you. I was just going to ask a question based on Rebecca's last comment about protecting people from fake connector plans when they go on to Google. Do we utilize SEO and SEM techniques to try to push the real connector up top?
We do, and I don't know, Jason, if you feel more able to speak to that, but I know over the last year to 18 months, we've made some adjustments that have been particularly focused on trying to get ourselves moved up when people Google for the health connector or affordable health insurance in Massachusetts, a whole bunch of different search terms. So that's really heartening to hear what Rebecca shared in terms of what the DOI is hearing. But Jason, do you feel like you have at your fingertips a little bit more detail on technically what we did?
No. It has been a priority, and we've taken steps in terms of, building up the keyword list, and making sure website copy is more sort of SEO grabby to make sure we've moved up. So it's been, I would say, the last year or so, it's been a focus of ours.
And do we put marketing dollars towards that too?
Sorry, Eric, I missed that.
Do we put marketing dollars towards search engine marketing versus? Okay.
We do, yes.
Great.
We do both for non-group and small group.
Great. All right. Thank you.
It's a great question. We can share more technical detail, Eric, but definitely a concerted effort with dollars attached to it. Great.
Excellent. If there are no additional questions, it looks like, again, thank you, Marissa, Patricia, Jason, Elizabeth over at MassHealth for this tremendous effort. Thank you. The next item on the agenda is a presentation on the individual mandate policy items, which will be presented by Kayla Sherry. The board will first vote to approve the issuance of the affordability schedules for calendar year 2025. And then there'll be a subsequent vote to approve the deductible limits for plan year 2025 as set forth by our staff recommendations. So to kick off the initial presentations, Kayla, you have the floor.
Thank you so much. I trust you can all see and hear me.
Yes.
Okay. Oh, there we go. Okay, good morning. Today I'll be walking through two proposals for annual updates related to the Commonwealth's individual mandate. First, we will review the affordability schedule, and second, we will review MCC deductible limits. Since 2007, Massachusetts has required adults to maintain health insurance, and the individual mandate remains an important tool in promoting market stability today. The federal individual mandate penalty is no longer being assessed as of tax year 2019, but the state mandate remains in place. The Commonwealth's individual mandate has wide reach and is applicable to approximately 5 million state residents. The Health Connector Board is responsible for a number of policy aspects of the individual mandate. And as mentioned, today's discussion will focus on annual updates to the affordability and coverage standards for 2025. Okay. So the affordability schedule determines whether an uninsured individual must pay a penalty for not having coverage. If an individual has access to coverage that is considered affordable, but they don't enroll, they will be assessed a tax penalty. Connector care is always designed to be considered affordable, and eligible individuals must enroll or pay a penalty. I wanted to review some of the things that the affordability schedule does not do. It does not require employers or carriers to offer affordable coverage. It also does not penalize employers or issuers if individuals fail to enroll in affordable coverage that they offered. And finally, the affordability schedule is independent of federal policies related to affordable coverage standards and separate from the determination of federal premium tax credit amounts. And then this last section on the bottom here, I just wanted to review how connector care enrollee contributions interact with the affordability schedule. So historically, the Health Connector tied the affordability schedule directly to connector care enrollee contributions.
For 2025, we're proposing to separate out individual mandate topics from the Connector Care enrollee contributions. Connector Care enrollee contributions will continue to be considered affordable, but separating Connector Care design from the affordability schedule provides more flexibility for the Connector Care program to set premiums, mitigates the unpredictable impact of inflation on Connector Care members in the future, and supports thoughtful program design, especially in the context of the Connector Care expansion pilot.
Kayla, can I ask
Sure.
a question? When it says that Connector Care premiums will continue to be considered affordable,
Yes.
is that regardless of what level we set them at compared to the affordability schedule? I mean, as you know, that was always the reason to tie the two, so that anyone eligible Connector Care would always have affordable coverage and therefore would have an incentive to join.
Yes, so the Connector Care enrollee contributions will always be considered affordable, so they'll always be under that affordability.
I see. Okay.
So it could be at the level, but instead of sort of tying it one for one, we thought with the pilot expansion and then what we've seen with inflation the last couple of years, the conversation, and because it gets confusing because we're talking about individual mandate versus our own program design, we thought it was better to keep them separate. Even if they do end up being the same some years, better not to make it sort of one for one every year as a policy matter.
Yeah, I think decoupling makes sense. I just didn't know if there was some statutory or regulatory thing that always made them presumptive. I think it always was before because they moved in tandem with one another. So, okay, thank you.
Thank you.
Kayla?
Yes.
I think the upshot of what Nancy said, and I had a very similar question, is by doing this, we allow the premiums to be below the threshold of affordability as opposed to at the threshold of affordability. But they would never be above the threshold for affordability.
Yes, that's right. Yep. They would always be considered affordable. Yep.
Yeah. The key, when you say they're decoupled, that statement alone makes one think, well, they could be higher, they could be lower,
Right.
whatever.
It's tricky.
But what you're really saying when you're decoupling them is you're allowing us to set premiums below what the affordability threshold would demand.
That's right. Thank you. That's an important point.
I think that's what Nancy was getting at.
Yes, but thank you for explaining what I was asking.
Thank you both. I don't think I see any other hands. I could move on to the proposed approach. So the proposed 2025 affordability schedule is consistent with the standards used in prior years before we started adjusting for inflation. For 2023 and 2024, due to high inflation, we proposed and the board finalized reductions in the percentage of income considered affordable. For 2025, staff recommend going back to the pre-2023 affordability percentages to account for easing inflation by 2025. Because the poverty guidelines are indexed according to the Consumer Price Index, they do increase in accordance with the higher inflation. The Congressional Budget Office reports that inflation will continue to slow and then begin to approach the Federal Reserve's target rate by about 2% by 2025. So reverting to the original affordability schedule means that for the purposes of determining whether someone is subject to the individual mandate penalty, affordable premiums based on income would be slightly higher than they otherwise would have been if we did adjust for inflation. So just to give you an example, individuals between 150.1% and 200% FPL or the federal poverty level would be considered to have access to affordable coverage that costs between $55 and $73 rather than $51 and $68, which is what it would have been if it was adjusted for inflation. So this table here is just comparing the 2024 and proposed 2025 affordability standards. So you can see the difference here for all the FPLs. And then this is the proposed schedule for individuals, for couples, and then for families. And I know there was a lot on those tables, so I will pause here for any questions before the vote. Okay. Don't think I see any. So that brings us to our vote.
Okay, I do not see any additional hands, and so with that, the Health Connector staff recommend that the board vote to approve the issuance of the affordability schedules for individuals, couples, and families for calendar year 2025 as set forth in the staff recommendation as final. I'll entertain a motion to continue.
So moved.
Second.
Kathy?
Okay. Rebecca,
Yes.
Michael,
Yes.
Elaine,
Yes.
Bella,
Yes.
Eric,
Yes.
Martha,
Yes.
Robin,
Yes.
Dimitri,
Yes.
Nancy,
Yes.
Matt.
Yes.
Thank you.
Thank you, Kathy, and the motion carries. Kayla will continue with the presentation on deductible limits.
Thank you. Okay, so our second individual mandate topic today is minimum creditable coverage deductible limits for 2025. So just some background on the deductible limits here. So MCC standards shape and reflect market norms for coverage in determining what kind of coverage is sufficient to avoid a tax penalty. MCC regulations allow for annual updates to MCC deductible limits. These adjustments allow individuals with market standard coverage to avoid tax penalties and provide the needed flexibility in designing plans that meet federal actuarial value constraints. Here, I'll review how MCC deductible limits apply to the market. So MCC deductible limits determine what kind of coverage an individual can have to check the box when they file their taxes. Without the periodic indexing, state residents may be unfairly penalized through the individual mandate, despite having coverage that meets reasonable minimum standards. MCC deductible limits do not require deductible changes for consumers. In addition, the deductible limits proposed today also do not impact high deductible health plans as defined by the IRS. So high deductible health plans that are compatible with HSAs and HRAs qualify as MCC under the Health Connector regulations, so no impact there. The Health Connector's MCC regulations state that MCC deductible limits are indexed annually using the premium adjustment percentage published by HHS, or maybe another amount determined by the board. The premium adjustment percentage is used by CMS to index the maximum annual limitation on cost sharing and other parameters in the Affordable Care Act. This percentage is a measure of premium growth from 2013 for a given year. And because of that, the percentage may increase or decrease from year to year. The 2025 premium adjustment percentage is 2.5% lower than it was in 2024, whereas in some years we see it slightly go up. Since the 2025 premium adjustment percentage is 2.5% lower than in 2024, indexed MCC deductible limits for 2025 would be slightly lower compared to 2024. Holding deductibles steady at the 2024 index limits may help to avoid surprising individuals with a tax penalty that they aren't expecting and ease market disruption. And you can see in this table what the indexed medical and then separate prescription drug deductible limits look like for 2024 compared to what the 2025 index amount would look like. And so again, we're proposing to freeze at those 2024 deductible limits. And while staff acknowledge that cost sharing deters care, of course, minor adjustments to or a one-year freeze on the MCC deductible limits are unlikely to halt the overall market trend toward increasing cost sharing, but they may result in penalties for individuals with generally robust coverage. And this is a trade-off to which we are sensitive to and think about often. But I will pause there for questions before we move on to the vote slide.
Okay, seeing none, the Health Connector staff recommends the board vote to approve the deductible limits for plan year 2025 as set forth in the staff recommendation. And so I will entertain a motion.
So moved.
Second.
Kathy?
Okay. Rebecca,
Yes.
Michael,
Yes.
Elaine,
Yes.
Bella,
Yes.
Eric,
Yes.
Martha,
Yes.
Robin,
Yes.
Dimitri,
Yes.
Nancy,
Yes.
Matt.
Yes.
Thank you.
Thank you. And the motion carries. I believe the next agenda item is a presentation preview of the 2025 Seal of Approval, which will be presented by Chris Herakowitz and Marissa Waltman. Chris, you have the floor.
Thanks, Elaine. So I'll kick off. Today we will begin our discussion of the 2025 Seal of Approval, or SOA, as we often refer to it. Marketplaces like the Health Connector are required to certify health and dental plans for sale to members, and we work closely with the Division of Insurance to make sure that plans meet all state and federal requirements. Today we'll review our approach for coverage beginning January 1st, 2025, which is hard to believe that since we just wrapped up open enrollment for this year, but it really speaks to how much effort has to go on behind the scenes to make sure that we have high quality coverage ready to go for our members each open enrollment. We'll be back several more times over the course of the year to update you on the SOA process. And with that, I'm really pleased to introduce Chris Herakowitz, who joined us last fall and leads our efforts in this space.
Thanks so much, Marissa, and thank you everybody on the board for your time today. Eager to dive right in. So as Marissa mentioned, we're here to talk about 2025 Seal of Approval. And as we look to the 2025 Seal of Approval, some of Audrey's comments in her executive report are pretty salient here. We are aiming to be deliberate and thoughtful, which means we are taking careful consideration of where we are right now in 2024 and how we got here, as well as looking ahead to 2026 and where we may need or want to go. And as you take a look at, and Audrey highlighted this and others have highlighted it, as you take a look at some of the, significant notable enhancements we've made across the Health Connector's product shelf in leading up to 2024, with all carriers participating in Connector Care, obviously the expansion of Connector Care to the 500 FPL, and the expansion of the broadest network. There's been some monumental changes, or at least notable changes. As we look ahead to 2026, there's also the possibility that enhanced APTC payments may not be what they are right now, may change, may go away. There's always the need for ongoing alignment between us and some of our partner agencies at the state level around equity topics, and obviously a continued need for us, and we'll talk a little bit about this, but a continued need for us to assess and potentially modify our premium smoothing approach. So when we look at those things on the left and the right hand side of this slide, that focus on program stability for 2025, we think is the smart move as we think about 2025 being a year of program stability wherever possible. So we're going to talk about a little more detail here, but I think we'll see how we are prioritizing that program stability in a number of ways, while also considering targeted changes and enhancements that will make a positive impact for the residents of the Commonwealth of Mass. Can we jump to the next slide, please? Because none of this happens in a vacuum, we have once again fielded a request for information, or an RFI. Many in the community, some of our carriers, as well as community-based organizations, brokers, consumer advocates, responded with a host of thoughtful feedback. One of the most notable pieces was around the administration's priority efforts on maternal health and cardiometabolic health. And there was a lot of support that we received in that RFI around improving the maternal health outcomes and advancing those cardiometabolic health goals. The responses varied and ranged from everything to underscoring existing programs and services and resources that are already there for folks, to finding ways to effectively enhance access to care providers, especially within the maternal care space. We also received some feedback on affordable coverage for small businesses. And while there was some varied feedback, most folks reinforced the need for us to support small businesses and their employees with flexible plan offerings, affordable coverage options, and a number of things that we believe we've already got through our Healthcare for Business offering. We're going to talk a little bit more about what we're looking to do in 2025 to help highlight those offerings. I'm going to pause here for any questions or comments on the RFI or that process. All right, if none, we'll move forward into two areas that we mentioned a moment ago that is a major focus for the administration and for us here at the Health Connector as well, which is maternal health and cardiometabolic health. I think the maternal health piece is relatively straightforward and then folks understand that. But sometimes when we mention cardiometabolic health, people have to pause for a moment. Quick reminder, it's a group of diseases that are common but often preventable, including heart attack, stroke, diabetes, insulin resistance, et cetera. And there are a host of diseases that can contribute to significant poor outcomes in adults, heart disease, et cetera. So it is a major focus. When we think about how the Health Connector is going to approach us in 2025, we'll start at the bottom here. There are a host of foundational programs and services available through the current Health Connector plans that we can probably do a better job of aggregating and highlighting for folks. So whether that be maternal support programs, whether that be specific programs that are helping people who are having gaps in social determinants of health, transportation, et cetera. And some of them are offered directly through the carriers, but others are available through the state or the community-based organizations. We can very likely address some low-hanging fruit here by collating some of that information together and making sure that it's actively communicated out to people so they know what is available to them. That's foundationally, but beyond that, the other thing that we're trying to do is be thoughtful and make some smart choices with our impactful policy. We want to base that on facts and data. So as such, we're looking to collect a series of information from some of our carriers around some of the outcomes they have in maternal health and some of the programs they have, as well as some of the outcomes they have and supportive programs they have in cardiometabolic health. So we'll collect that data, assess it, try to identify gaps, and use that information to make future policy decisions that can positively impact these two areas. And last, but perhaps most importantly, when we think about maternal health, we really want to benefit from the collective experience and knowledge of so many who are focused here. And we want to do so by pulling together a group of key stakeholders who can help us find the right path to improving maternal health, whether it's a combination of existing programs or net new programs, and specifically with a focus on some ongoing activity in the state for certifying services such as doula reimbursement. We want to go down that path in a way that's going to be effective for all those we serve. I'll pause here in case there are any.
We'll advance Mike first, and then I have a thought to add.
I just want to, there's a little bit of an emphasis of something that I think is going on and a little bit of a question. Sure. As part of the seal of approval exercise, my understanding is this is mostly about how we set our cost sharing rules. So making sure that our cost sharing is consistent with some of these types of programs. My understanding is that most carriers would have programs to support a number of these types of things, maternal health services, cardiometabolic services, diabetes and things. So there's a lot of activity carriers are doing. And my sort of experience has been that oftentimes the cost sharing provisions of health plans may be at odds with those other initiatives. So there may be a program to get women to have more prenatal care and a benefit design that charges them a lot out of pocket for that prenatal care. So my sense is the seal of approval portion of this is all about cost sharing. And then my question is, how much of this is beyond just how the seal of approval cost sharing stuff is, or how much of the seal of approval is about payment methods, use of other types of programs, things that are not really directly related to the benefit design structures that would show up in cost sharing?
Yeah, I think that, I'd welcome any others from the connector to weigh in as well with some perspective. But I think what you've hit on, Michael, is there are existing programs in place. What are their barriers? And in this case, specifically, the out-of-pocket costs that some of these individuals may have to put up to access some of those programs and services. That's part of what we're hoping to address here, is get a better handle on what is included with either no additional out-of-pocket cost, or what is something that's going to be subject to some of the cost sharing within our standardized plan designs. We're going to talk a moment about how we're thinking about those plan designs and the specific cost sharing for the 2025 plans. And the news there is we are primarily prioritizing stability so that the cost sharing would stay the same. But I think we've got more to learn, candidly, about how some of these programs can be adequately accessed and whether or not there is an out-of-pocket cost for members to access certain pieces of the program.
If I could just add a little bit to, Chris is right, but to your kind of foundational question, Michael, about SOA, yes, it's about product design, program design, cost sharing, benefit details, yes. And as you know, we've put forward, forward-leaning policy on some of those changes over the years, particularly in connector care. SOA is that we're not proposing, benefit changes here per se, but SOA also is the foundation by which the connector contracts with these carriers. And the process allows us to solicit data from them, information from them, or require particular activities on their part. So just as examples, in past years, we've required particular activities from carriers around convening member councils to advise on gender affirming care, services for transgendered folks, et cetera. We're requiring carriers for plan year 2024 to do more promotion of preventive services because we can see in our data that low-income folks aren't as likely to avail themselves of those services. So I just wanted to note we have the ability to do both. And that's part of what I think the data piece is looking to inform, because there may be benefit tweaks down the road we want to consider, but we want to do it with information that we're able to collect through SOA first.
So just to summarize, my narrow view of SOA was wrong because I viewed it just as how we set the tables that tell you what the deductibles are and all that stuff. But what you're saying is the seal of approval process is broader, that as part of that, we could also require you to have a whole range of programs to support these things independent of what your actual benefit design is.
That's correct.
That was just a mistake on my part. Thank you. Now I'm informed.
Absolutely. All right. And I think I see a couple of hands here, Philan, I believe.
Yeah, not a question, more of just lifting up the importance of one of the foundational support points that you have there, and it's the kind of promotion of the relevant social determinants of health resources and just how important that is, because we know that, patients will, forego necessary treatments, especially along the cardiometabolic health factors that for other things, housing and just all of those other cost of living needs. And so just lifting that up, because I think it's extremely important. They run parallel together.
Agreed. And I think to your point, it's one of the reasons that we want to do this in a holistic and effective way, right? So it's one thing to point to programs available through carriers, but if people can't get to those programs because they're impacted with transportation needs or any of the number of social determinant of health needs, then it's sort of moot, right? So we want to try to do this in an effective way. Thank you.
Great, thank you. Nancy and then Robin.
Thank you, Philan. So Chris, this is very exciting that we're continuing and enhancing our focus on health equity. One of the challenges of having such a fragmented financing system in the US is there are often so many good efforts going on by particular payers, by particular provider systems. So I'm hoping as we continue to do our work, and it's kind of implicit in the subheader of this slide, that we're trying to find every opportunity we can to be coordinating and working in partnership with other state payers and whomever else we can. I mean, I think we have a lot of history over, and this is one of the problems of getting older, you kind of have experienced some of the history of lots of fragmented efforts, each of which was really well-intended and good, but somehow never realized the potential that they could have had. So it's more of a comment, but if you have anything as you go through this to kind of add how we're collaborating with us, including the Health Equity Compact, which Philan has just been such an important leader of. So we're at this wonderful moment through leadership of so many people that, every way we can be collaborating, I think is really important for our piece of this to have maximum impact.
Appreciate
you want
that. I can think of one example, even as we look at maternal health and we think about choices we may want to make going forward, around the doula coverage, right? I think folks are generally aware DPH has a concerted effort here to go down the path of some sort of centralized certification. And there's an example, just one, but to your point, Nancy, I'm sure there are many more that we can take advantage of, but there's an example of a collaborative effort that we are tied into and trying to stay close to.
Yeah, great. And I'm not at all implying that I don't think that you are, but more saying carry on and collaborate as much as you can.
Yeah, if I could just quickly chime in here, Matt from the GIC, you're singing from our song sheet, Nancy, Audrey's and mine, and Mike Levine's and Gary Anderson's. I think the equity work here that the staff is highlighting is one really good example of that. So you have the connector, the GIC, and MassHealth all sitting around the table and making sure that we are aligning our strategies as much as we can, specifically with what you suggested. That's what we have in mind, right? If we can all align our efforts, acknowledging that each of our we operate differently, right? We all have different rules and tools and levers, but if we can adapt them moving in the same direction, I think that will be really helpful just for the Commonwealth. So we're certainly doing that in the equity space. I've talked with Audrey and a lot of our colleagues about other areas in which we can do that. A good example, I think, is some recent engagement with MassHealth to understand how they are specifically structuring the ACO model to get at social determinants of health through contract requirements and measures of progress and performance guarantees. Like, all of these things are really helpful to us as colleagues to kind of get where you're headed. I think there's a really strong opportunity to do that.
Yeah, I think that there is too. And I wish we would declare this a no compete zone, in the sense of everyone will not do their own thing, but everyone will collaborate together. So it's great to hear, Matt, all the efforts that are underway. And
You look like Eric has his hand up.
I don't want to be out of order. Did Cynthia have a?
I think I did.
Robin, you had your hand up.
did,
Go ahead,
yes.
Robin.
Maybe it's the same. I don't know. No, that's okay. No worries at all. I just have a quick question. When I'm reading this, I see that the carriers will be asked to report data on the GLP's coverage approach and utilization, which prompted a question. Are the benefits in general required to be aligned across the plans? So for example, on this one, are all the carriers required to, I should say carriers, not plans, required to cover GLP-1s, and are in this, it sounds like not in the same way, but I'm just wondering if they're all required to provide the same kinds of coverage.
Yeah, it's a great question, Robin, and the answer is it depends on what elements of the coverage we're talking about. So in this case, for example, for GLP-1s, to my knowledge, we don't have a specific requirement beyond anything that may exist at the state level, which does not exist in this case, to my knowledge, about that. And so given the expansion and really big growth of the utilization of these GLP-1s, we are trying to solicit information that could inform a decision that we might make down the road that may provide a little more uniformity about how that is addressed. But at the moment, this is an example of something that is not necessarily standardized. There are other elements of the coverage that we define in the standard plan designs that are relatively standardized, such as the cost sharing and some other pieces, that tie back to how the ACA defines, for example, a qualified health plan, right? So there are things within that are standardized, but this is an example of an element of coverage that is not covered.
Great. Thank you very much. That's helpful.
Absolutely. Eric, I believe you were next.
Yeah, thank you. Just very quickly, I'll say in the insurance industry, we call some of these things, when we look at maternal health, cardiometabolic health efforts, we call them point solutions. And I would look to, just as we're going forward, consider all the carriers are independently looking at point solutions. They'll often evaluate and then bring in plug and play innovators, startup companies and more mature companies to focus on these areas. So what we could do, if we don't want to reinvent the wheel, we could be looking at what all the carriers are doing, and maybe a little bit outside the carriers in our local area. It could be national carriers and others, and see what plug and play options they're using for these types of point solutions. And that would be something that we could leverage and implement across the board. That's all. Thank you.
Yeah, much appreciated. I think to your point, we even saw in some of the RFI responses that some of the carriers sent over, some carriers pointed to some of those very point solutions that they have either actively deployed or that they've got out there in the marketplace. But it's a good call in that we need to be aware of what those solutions are. Right? If there's something out there that's being really impactful in the maternal space, and there are point solutions that are effective, then maybe there's more digging we need to do about that as a holistic solution that we could propose. So appreciate that, Eric. Okay, any other questions here? I just want to be conscious of time as we, okay, great. If we can move on to the next slide. So another big focus, and this has been discussed in more than one venue, maybe most notably by the governor herself during the healthcare, during the Health Policy Commission's meeting in November, but affordability for small groups is a major focus of the administration and of course the Health Connectors. We believe that we have, through our Health Connector for Business offering, a series of sort of existing value that we're really looking to highlight. And so given that focus, we're going to conduct a sort of a multi-pronged effort. And in the spirit of Michael's question about what is SOA and what is the scope of SOA, and in the spirit of mine and Audrey's response about what that means, some of these are a little outside the scope of the seal of approval. So there are some things that we at the Connector will be doing from a sort of campaign and highlighting point to for example, showcase some of the program flexibility and the models that we have right now in our Health Connector for Business offering that we think provide value to small employers and their employees. There is a wellness rebate that is exclusively available through the Health Connector for Business that we'll be looking to highlight. And so those would be things that are, sort of technically outside of the seal of approval, but within the seal of approval, we're looking to highlight existing plans that have a high value. For year one of this initiative, we're focused primarily on affordability. And I want to note that we recognize that premium affordability is not the only aspect of value, but from a starting point, we're going to be highlighting health plans that have premiums that generally are beating market averages within the healthcare for business offering, which I think just underscores the overall value that people have from a premium affordability standpoint. And because so many of those plans, if not all of those plans, have an inherent built-in value around their network access and the plan designs, we really think that this is something that we hope is going to resonate with the market. All right, next slide, please. So we've got a couple of slides here discussing the topic of network adequacy. And when we speak about networks, we mean provider networks specifically. As you all know, all the carriers that we work with maintain their own versions of contracts and provider negotiations and ultimately provider networks with the providers whom their members are able to see. There is a federally proposed rule which would make a significant change to current state around network adequacy, which is really the assessment of provider and access within a certain region, and is it adequate based off of a certain set of standards. As things work right now, which is noted on the slide, the Division of Insurance assesses that network adequacy, and we partner with them in some of that, and being good partners around QHPs, ensuring that they meet those adequacy standards. We also have an additional level of network adequacy standards that we at the Connector layer in for our Connector care population. This new proposed federal guideline, however, would take some of those standards and turn them a bit on their heads, in that there's a series of additional provider types that the feds are proposing get included in network adequacy. And then also the process by which network adequacy gets assessed is specifically being looked may change if this rule is finalized. I should note, this is a proposed rule that at the moment has not yet been finalized. And if we can jump down to the next slide real quick, you'll see that our thinking at the moment is to hold status quo around our current language on network adequacy, because we don't know whether or not this will change, and we won't know by the time that we are likely to release the seal of approval documentation and start to launch that process. We're likely going to hold that language for now and amend if and when that language does get finalized by the feds. So you'll see on this slide right here, that noted on the left, if the rule is finalized as it is currently proposed, we'll amend the RFR language for the seal of approval as needed and work closely with carriers and the Division of Insurance to operationalize those standards. If it's not, we've laid out sort of 3 different ways that rule may change. They could either change the standards themselves that they propose, they could modify the timeline that they had originally proposed this be operationalized for, which was for plan year 2025, or they may scrap it and not adopt anything. And then depending on where we go, we'll adjust our approach accordingly. I will pause here because I realize network adequacy and network adequacy standards are probably not something that everybody looks at every day. So, open to take questions here. Okay, next slide, please. So under the banner of networks and provider networks, we have received some feedback from the marketplace, both from consumers, from carriers, and even some brokers, that there's an opportunity for us to provide some additional flexibility in our plan design options. And so we are proposing for the 2025 plan year that providers could actually propose a design, a non-standard design, that would include a multiple tier network benefit. And what that means is they would take their existing broadest network that carriers have available through the Health Connector shelf, and they could tier those providers in a manner such that they could then apply differentiated copays to each of those provider tiers, and ultimately incentivize utilization at lower cost providers or lower cost sites of care. This is a plan design that is and has been available off exchange for a number of years, and it's something that we think can offer a lot of value on exchange. It would not be a requirement. It would be an option for carriers to design and propose this. It would be something that we'd be looking for on, that we can propose on tiers outside of our existing silver tiers, given how we leverage the silver tiers for the connected care population. I see a question, Nancy.
Yeah, thank you, Chris. On this one, kind of one question and maybe a comment. I admit to being quite skeptical when we give carriers lots of flexibility to design new products that they often, I think, lead to having configurations that are sometimes designed to select certain kinds of people to enroll. So I would just say, in thinking through this one, and when we see what the carriers propose, I would ask that be like part of what we're trying to assess. And then, are there instances where within a provider network, some providers participate and some don't? And could people be in a situation where they think they're going to a lower cost tier provider within a system, and then they discover that type of provider, that individual provider, might not actually be in the tier, so they'll get surprised. They'll be surprised that they have higher cost sharing than they think.
So on the first part, noted and understood that, with something new, right? When we get or anybody proposing something new, that we are certainly going to have numerous eyeballs on those plan designs and trying to think towards all the things that we prioritize around equity, access, affordability, right? On the second part, I want to make sure I'm understanding the question. So are you asking whether or not plan designs that it opens up the opportunity for people to inadvertently seek services from a provider, but not recognize that provider is going to be at a higher out-of-pocket cost?
Yeah, or they go and get care, and they have some doctor come in to give them services, and even though they're at the lower cost provider, the individual clinician may not be. So I don't know how we deal with that, but there are lots of examples kind of that you hear about where people are surprised that somebody who often they had absolutely no ability to, they're lying on the gurney and they're, and they're not going to say, excuse me, before you help me, would you tell me if you're in network or not? So just if we could pay attention to that. I think our general posture should be whenever we add additional options, we should be very careful about it because, choice is good. Some amount of choice is good. Too much choice is confusing and opens up opportunities for other things. So we already have so many different plans on our shelf that I think our bar of adding other plans should be really quite high.
Understood. And I think what you're also raising here that we've talked about, but that I think you're reinforcing needs to be a focus of this is if in fact carriers propose some of these plans, there's going to have to be a concerted consumer and member outreach and education piece of this as well, so that they understand how these plans work. To your point, there are certain scenarios where somebody wouldn't have that ability to maybe make a choice at the moment that they're seeking care, but at least if we can provide the tools and the resources necessary while people are upfront making the plan selection, hopefully we can try to head some of that off at the plans.
Yeah, I think I'm also saying that we already have a lot of plans. When we decide to give more flexibility, which the carriers already have quite a bit of, we should have something very specific in mind that we're trying to achieve. And if it turns out we don't achieve it, or there's not some threshold of market interest in it, I think we should think seriously of not offering it the next year because we have a lot of products already. So
understood. Okay. Appreciate the point.
I believe we have Eric and then Rebecca next.
Thank you. I'm very supportive of this type of design. I've been working with this kind of design for years off exchange. So just to give some context, I agree with Nancy that we shouldn't just add more options which add confusion, which don't have specific purposes. The purpose of this kind of option, this is how I see it. Right now, what we have on the connector are a lot of a lot of carriers and a lot of plan designs, but enrollment is really, really limited to Tufts Direct and WellSense. Tufts Direct and WellSense represent limited network plans. That means that the network is smaller than the full Tufts network. The WellSense network may not be as broad as, say, Blue Cross's full network. And so we have those narrow networks on one hand that are affordable options. And then we have these full networks that we have seen are very expensive and are not accessible to people. And so what this tiering design offers in the other side of the market, in the private marketplace, it offers someplace in the middle. It offers all the providers that are in the regular broad network. However, at the point of service, a patient makes a choice as to whether they want to pay a higher copay or a lower copay, depending on which hospital they might go to. So it allows them access to everyone, but it gives them a choice at the point of service as to what is most valuable. And this kind of design would typically, from a cost perspective, come in somewhere in between our narrow network, limited network plan designs and the full network. So it's somewhere in between for people. And moreover, it is consistent with what we saw from the HPC's studies, where it said that one of the drivers of cost in our state is that same services cost different amounts depending on where you go. So this is one way to help recognize that driver of cost and try to use market forces to help control it short and long term. Thanks.
Yeah, if I could just respond, I appreciate that very, very much, Eric. I have no objection to trying this. I think one of the things I would ask is, I believe we have an affordability crisis that we will not be able to design our way out of. And with each attempt to do that, we make it, in my view, a lot more confusing for people who are going to shop on the exchange. So I think whenever we add new benefit designs, if they don't prove to enroll a lot of people, or if they do, then we should go back and look and not just keep adding and adding and adding. I'm not really suggesting Chris or connector folks that we haven't done this in a thoughtful way, but there are a lot of options.
Appreciate it, Nancy. And the point is well taken in that with anything new, we need to look and assess. I mean, it's honestly, it's sort of the theme of 2025. We are attempting to see how some of the things that we've even done over the last year or two, how they are playing out in the market, how the market responds to them. And the market are consumers, right? Are they buying these plans? But it's a noteworthy call out. Rebecca.
Yes, I just wanted to agree with what everyone's saying. The plans are out there, but there's been extremely limited uptake, I think, in the insured commercial market. And the carriers currently are reviewed for their materials to make sure that it's prominently displayed in the policy, that there are tiers in the network and how they work. And the division has received very limited complaints in this area. So it hasn't proven to be a problem with respect to consumer misunderstanding or out-of-network bills, that sort of thing, to this date. But as has been pointed out, there is a small uptake in the market at this point in time.
Yeah, that's great to hear, Rebecca, and that's reassuring. So thank you.
Okay. All right. Next, we have a few updates around our Connector Care program. Under a similar banner of equity and focus, we have done some digging here at the Health Connector, and we are happy to say that we are proposing the elimination of some targeted drug co-payments for those Connector Care members that fall below the poverty line. So these would be Connector Care Plan Type 1 enrollees who fall below the poverty line, where we have an ability here to eliminate some of the copays. And as some studies have shown, even nominal out-of-pocket costs for things like, maintenance meds or ongoing medications that people have to take to address some of their conditions can be prohibitive for some individuals. And so we're excited about the opportunity here to eliminate some of those out-of-pocket costs for prescription drugs for people who are below that federal poverty line. This is not dissimilar from an approach that MassHealth has taken to eliminate prescription drug copays during the pandemic. And we took a bit of a cue from there, back to the whole collaborating and coordinating amongst fellow health-focused agencies. And we're eager to bring this to market. Okay. Next topic is our premium smoothing. So as we think about premium smoothing, and I know that is a topic that's been in focus for the board for a bit now, as we think about premium smoothing for 2025, a quick reminder that premium smoothing is a tool that helps the Health Connector ensure that Connector Care members have a number of available and affordable options, while still attempting to incentivize enrollment in low-cost plans. We've done this in various forms over the years, and it's all in an effort to balance several competing goals around cost, access, and program stability. Last September, the board discussed premium smoothing for 2024 in the context of a wide variation of premiums that we saw from carriers for the 2024 plan year across the silver plans. And, in an effort to support what meaningful choice is for Connector Care members and addressing some geographic gaps in coverage options in certain regions of the state, we continued with a premium smoothing approach, and we set a cap at which premium smoothing would apply. And so for 2024, that cap was $375, meaning any plans that were $375 more than the lowest cost plan did not qualify for any premium smoothing dollars. For 2025, we're looking to maintain our premium smoothing overall approach for the time being, but adjust that cap downward so that plans no more than $250 more expensive than the lowest cost plan would receive this premium smoothing. And then of note for 2026 and beyond, we think a number of things that will be happening in the market. The time will be ripe now for us to think ahead to a future strategy in 2026, where maybe premium smoothing evolves in a more meaningful way, anchoring ourselves against what we're trying to accomplish and thinking about maybe more creative ways to do it. Okay. Barring any questions on premium smoothing. So this got touched upon during Kayla's presentation as well and the vote, but the connector care enrollee contributions, as was mentioned, have been decoupled from the indexing tied to the affordability schedule. However, we have based the proposed 2025 connector care enrollee contributions on a 3.3% inflation assumption, which is been evolved a bit given some of the significant inflation we've seen over the last few years. You can see on the page here that there are some increases. We've got that third line down with the current 2024 minimum contributions, and you'll see each of the 2025 proposed contributions have gone up by that 3.3%. In most cases, it's a few dollars. It does, as you go up the scale towards those that are making up to the 500% above federal poverty level, it does increase more than a few dollars for each level. Any questions here? Excellent. All right, the next several pages are, let's highlight some next steps. We do have in an appendix, which we don't have to go through in gross detail, our numerous plan designs. Maybe we can jump ahead to the plan designs real quick before I hit next steps. Can you actually go real quick? Okay, we'll land on this page. I realize this is an eye exam for a number of folks. Hopefully you have a chance to look at it in a little more detail. And if there are specific detailed questions, I'm happy to answer them. But the headlines here for our 2025 plan designs are, once again, program stability. By and large, with the exception of the high gold plan, which I will highlight in just a moment, we are maintaining the structural plan designs and all of the cost sharing across all of our plans for 2025, with four exceptions. There's the gold plan I just mentioned, which we'll get to in a moment, but the high silver plan and the bronze plan will have their out-of-pocket maximums indexed to match the federally released indexing. So those out-of-pocket maximums will actually go down slightly to $9,200 and $18,400 respectively for individuals and families. The rest of those plan designs will stay the same for between 2024 and 2025. We can go down to the next, quick through two slides, please. To the gold. So in the gold plan design, this is the design for 2025 that probably has the most significant changes year over year from 2024. And what we've done here is layered in an annual deductible of $1,000 individual, $2,000 per family, and also made some downward adjustments to some of the co-pays that are applicable after the deductible for certain utilization categories, such as inpatient or skilled nursing. We think that this will be more in line with offerings that are available outside of the connector, and also something that will allow the carriers hopefully to provide a competitive price point for a gold plan that's a bit more aggressive than years past. Are there any questions? Maybe we can go back up to two more slides to the overall plan designs real quick. Any questions on plan designs before I jump back up to next steps? Okay, great. We can jump back up real quick. So I think most of you have heard or know, we've been socializing some of our thinking here around the 2025 seal of approval for a little bit now. Really pleased that we have the opportunity to discuss it at this board meeting, but we are also accelerating some of the timelines here. I think this is probably the earliest or among the earliest times that we've been able to spend some time discussing the seal of approval in February of this year, and we are targeting the release of the seal of approval RFR the end of this month or early next month, which would put us a couple of weeks ahead of where we were last year. All of this is in an effort to try to be more responsible to what's happening in the market. There have been some recent changes at the Division of Insurance that have impacted carriers as to when they're filing their rates. And we also know that there's a number of things going on. And so there's been some requests from carriers to accelerate this, and we are doing so. We also have already started convening some of our early thinking and some groups to take a look at 2026. As I mentioned at the beginning of this discussion, we think that there could be some significant changes that we need or want to make when we look ahead to plan year 2026 seal of approval. And so that work is already starting in earnest now in an effort to not just accelerate timelines, but give us the time to make, smart, thoughtful, fact-based decisions. And with that, I will pause for any overall questions, if any. And if not, I will pass it back to Elaine, I believe.
Thank you, Chris. Nancy?
Yeah, I just wanted to, Chris, thank you. Thank you and everyone else who's been working on this. I know everything you've talked about, it's very painstaking. It's very detailed. It requires a level of care and expertise and being in touch with the market and relationships with carriers. So just thank you. I think this approach seems really careful, very well thought out. So just wanted to recognize that.
Much appreciated. And as you know, it's a team effort.
Thank you, Nancy.
Well said, Nancy, and I concur. Our next, it looks like we have concluded our agenda items, and the last action is to adjourn. Obviously want to thank the board once again and everyone on the Health Connector staff for our discussion today. And of course, just the lifting up the health equity commitment in our Commonwealth, and also the commitment to affordable and accessible plans. So with that, I'll entertain a motion to adjourn.
So moved.
Seconded.
Kathy?
Okay. Rebecca?
Yes.
Michael?
Yes.
Elaine?
Yes.
Bella?
Yes.
Eric?
Yes.
Martha?
Yes.
Robin?
Yes.
Dimitri?
Yes.
Nancy?
Yes, with congratulations and thanks to Fellaine for her skillful inaugural chairing of this rowdy group.
Here, especially with the internet curveballs.
And yes for Matt.
Okay, thank you, Matt. Thank you, everyone.
Thank you. The motion.
Bye, everyone.
Have a great afternoon. Have a great day, everyone.
Thanks, Fellaine.
Thank you.